So I'll be talking about post-cataract surgery dry eye. How many of us see patients like this? Perfectly done cataract surgery, the eye is quiet, lens is perfectly centered, vision is 6x6 N6. You feel that this patient will be so happy. But he keeps coming back every 2-3 weeks complaining, chub raha hai. It's not comfortable, I'm having itching, watering, some foreign body sensation. And that really ruins that entire beautiful cataract surgery experience that you try to give to your patient. So is it a real problem? I think yes. All of us see it. Whoever is doing cataract surgery will know. Why does it occur? How can we treat it? How can we prevent it? Studies have shown that the most common cause for dissatisfaction after cataract surgery, the foreign body sensation, floaters, and residual refraction are the three main things. And in that, foreign body sensation is number one. Dry eye is really the most common complication of cataract surgery, not just among the early complications, even among the late complications. There are patients who will keep coming for months after surgery, complaining of discomfort in their eyes, and they will blame the surgery for their discomfort. There have been enough studies showing that post-operatively there is definitely an increase in dryness and as high as 70-80% has been reported. So this was one such study which shows that there was an increase at about 1 week in not just symptoms but also other parameters such as Schirmer's, etc., which then becomes better over the next 2-3 months, but still takes a long time to reach the baseline. Dry eyes does affect the quality of life, and even all the important activities for the patient, like reading books, operating a computer or any ATM machine, driving at night, watching TV, all these activities, it can variably affect from slightly to significantly in a majority of the patients. This study from Cho et al. Showed that the TBOT is significantly impacted from pre-op 10.86 to even after 2 months, it doesn't come back to baseline. It's about 6.8, which is definitely a reduced TBOT. And similar changes in tear meniscus height, etc. This, of course, is lesser, but I think it's more of an evaporative dry eye that we see in majority of our cases. So what are the causes of post-surgical dry eyes? I think it's a multifactorial thing. Surgical trauma itself, sometimes intraoperatively, you can create some epithelial injury. The patients, after the block, the lid closure may not be appropriate, or they may have some ptosis, altered corneal curvature from the procedure. Inflammation, of course, is there after any surgical procedure. Exposure to preserved medications, I think, is one of the very, very important factors, and we are dosing them quite frequently. Antibiotics, NSAIDs, steroids, everything has preservative. Anesthetic drops intraoperatively and preoperatively. Conjunctivochalasis is again a very common thing which many of our old patients have. And if we are just addressing the cataract and we don't notice these folds of conjunctiva in the inferior bulbar conjunctiva, they can cause a lot of friction every time the patient blinks, and then this kind of gets worsened because of all the drops that we are using, and the patients can then start complaining of this vague, watery kind of a sensation in the eye and irritation and itching. And a simple way to treat it is just intraoperatively you can tighten the conjunctiva and prevent a lot of discomfort post-op. Trauma to the sensory nerves because of your incisions also could be one of the reasons for postoperative dry eye. So we all know about this vicious cycle of dry eye, tear film instability, tear hyperosmolarity, apoptosis, and inflammation. And it's a self-perpetuating cycle, and a lot of factors can play additive roles at different levels. And you can see ocular surgery right there next to inflammation. Again, this is another table showing the various ways in which any ocular procedure like cataract or LASIK can result in dry eye, from disruption of corneal nerves, damage to goblet cells because of surgical trauma, and alteration of shape, etc., eventually through several pathways resulting in dry eye. So most cases that develop dry eyes have probably got some sort of a pre-existing subclinical dry eye, which we don't really pay attention to because we are just focusing on the cataract. So it's important to see these patients, spend some time to evaluate dry eye, because afterwards it's more difficult to treat. If you pick up a preoperative dry eye and address that, then you will have a more smooth post-operative outcome. So which are the cases which are at high risk for post-cataract dry eye? Patients who have low T, but this is a simple test all of us can do. We are anyway staining the cornea. So before you do applanation, just put the fluorescein in and see after a couple of blinks how much time it takes for the first random dry spot. And if that is anywhere less than 5 to 10 seconds, then you're looking at a significant evaporative dry eye which needs to be addressed. So then you look at the meibomian glands, etc., and see what needs to be addressed. Of course, other parameters like low or borderline Schirmer's. Conjunctivochalasis, again, is something we must look for. These are folds of conjunctiva, usually inferior or inferonasal in the bulbar conjunctiva, and they prevent surfacing of the tears properly, and the tears may not be able to come from the lacrimal gland till the lacrimal punctum, and they may flow out from the outer side. That is one of the clues. And improper or incomplete blinks. Many people blink, but they don't close their eyes completely during a blink. Patients who are having nocturnal lag of thalamus, all of these can have post-cataract dry eye. So identify these problems and address them so that you won't have post-surgical dry eye. Patients complain of all these things: foreign body sensation, irritation, stinging, etc., etc. The key thing is sometimes the eye will look absolutely normal, but they will have a lot of complaints. So symptoms are a lot more than the signs, and that is again one more hallmark of post-surgical dry eye. And of course, if you look carefully, you can see these subtle signs which will help you identify the cause. So this was just one paper showing there's a significant reduction in goblet cell density after cataract surgery. So that could explain one of the reasons why one has post-cataract dry eye. And we know goblet cells produce mucin, which is important in tear film stability. So we've identified the problem of post-surgical dry eye and the causes. How will we go about to address? Now you have this problem. How will you address it? Okay, if you have a pre-existing condition like blepharitis, meibomitis, conjunctivochalasis, please go ahead and address it with the management strategies which we all are aware with. Tear supplementation is the mainstay of treatment for any dry eye. So lubricants have to be used, and you could combine them with anti-inflammatory therapy like a short course of steroids or topical cyclosporin if there's a component of surface inflammation as well. So this is just a small surgical video. I thought since most of us are cataract surgeons and our phaco machines often have a cautery probe, if you see loose conjunctiva preoperatively, just go ahead and tighten it. You can just cauterize it, or you could even cut it and just cauterize the edges or suture them or apply fibrin glue, whatever you like. So this is a very simple thing you can do, just like a barber cuts hair. You hold the excess of conjunctiva between the limbs of your forceps and just shrink it with heat cautery. So lubricants, it's all about tear supplementation. Artificial tears is a misnomer. How do they work? Lubrication, reducing the osmolality, replacing the constituents of your tears, and diluting and washing away any inflammatory cytokines. These are all the things that ways in which lubricants help. What do lubricants contain? They contain a hypotonic or an isotonic buffered solution with electrolytes, surfactants, and various type of viscosity agents, and of course many other additives which are available in the newer better drops which are available. Another key component is the preservative, especially if you're going to be dosing frequently more than 4 times. Preservative becomes very important, so you want to go for either preservative-free or low toxicity preservatives rather than the traditional toxic preservatives like BAK. So these are the various viscosity agents available in lubricants. Though in the olden times we were using HPMC, CMC more. Nowadays we have PEG, polyvinyl alcohol, sodium hyaluronate has become the new kid on the block, and of course HPMC is making a bit of a comeback as well. So HP guar is another very nice additive which is there in some of the newer drops, and basically this is a material which is pH sensitive, and at a higher pH it basically forms a reversible cross-link with borate, resulting in a gel matrix on the ocular surface. And this spreads over the conjunctiva and the cornea, and this basically retains the tears or the lubricant on the ocular surface for a longer period of time, and increases the tear stability, similar to what mucomimetic effect that mucin has. So it improves the retention time of whatever formulation of lubricant you're putting, and provides relief by itself because it forms this protective layer on top of the cornea. So it has a mucomimetic action like mucin, maintains the tear film, and protects the corneal epithelial cells. Sodium hyaluronate is omnipresent in the body. Joints have them, even our eyes have them in the vitreous. And it's a natural component of tears as well, with a proportion of that on the ocular surface being synthesized by the corneal epithelial cells itself. So sodium hyaluronate effectively binds water and resists dehydration, promotes epithelial wound healing. There have been enough studies which have shown that it accelerates wound healing. And it has a viscoelastic property which enhances the residence time of the lubricant on the ocular surface, which is something we want. We want the lubricant effect to stay longer and not get washed off very quickly, because then you'll need to keep dosing frequently. Owing to the large number of negative charges on the molecule, sodium hyaluronate is capable of holding large quantities of water and thus lubricating the surrounding structures. So 1 gram of sodium hyaluronate can hold up to 6 liters of water, and therefore evaporation of water from HA eye drops is slow and the beneficial effect remains prolonged. And I think that's one very, very important feature of this particular viscosity agent over the others that are available in the market, and that's why I think it is so popular nowadays. In addition, fibronectin is an extracellular matrix protein which stimulates epithelial cell migration and accelerates wound healing. And HA binds to this fibronectin and forms a complex which enhances the wound healing. So especially if you have patients with pre-existing dry eye, where you're likely to have a bad ocular surface, this may actually help the epithelium to heal faster. So the viscous properties of liquid and elastic properties of solid together are called the viscoelastic. And basically, there is something called shear stress, which is the force between the tears and the ocular surface. And this shear stress actually helps to kind of align the molecules of sodium hyaluronate so that they get a viscoelastic kind of a pattern, and that's how they are able to last longer on the ocular surface. So a combination of HP guar with PG has been there for a long time, and now we have this dual polymer which is available from Cipla, which has a combination of HP guar PG along with sodium hyaluronate, which is, I think, a very good marriage of some very good things. And it increases the tissue hydration and lubricity. Sodium hyaluronate and HP guar may protect the ocular surface from damage associated with the dry eye. And the gelling gives a mucomimetic action, like I mentioned earlier. So you get a kind of a replacement of all the layers of the tear film to some extent. Sodium hyaluronate improves the lipid layer thickness. PPG, PEG, and HA act as a viscosity enhancer, provides lubrication. HP guar improves mucomimetic action, and sodium hyaluronate accelerates the corneal wound healing. So there have been studies showing how this combination can actually help. So this is one such study from Arif et al., who have shown that there is an increase in T-beauty after 60 minutes of installation of HA with HP guar combination. This is again from the same study, increase in the tear meniscus height 60 minutes after. So this 1/3 of patients undergoing cataract surgery do have dry eye symptoms. We mentioned about this earlier. This was again another study showing a significant reduction in the speed scores compared to patients who did not use artificial tears. And again, in this, they had two subgroups: one who received lubricants even before the surgery was performed, and that did even better. T-beauty scores, of course, you can see are significantly better compared to no drops. So I think that's like a no-brainer. Again, this is a study comparing control with HP-GOR alone, HA alone, and a combination of HP-GOR and HA. And you can see that it has done very well for protection against desiccation. This is a study showing the reepithelialization. So they've induced trauma on mice, 16 mice, and then seen how fast the reepithelialization, and the combination of HP-GOR and HA had the fastest and maximum reepithelialization compared to the other individual components and different concentrations of HA alone. So that's about lubricants. The final leg was the
Rishi,
role of...
can we
yes.
hurry up here?
Yes, anti-inflammatory therapy. So I think we have a lot of agents. Topical cyclosporin is something we often use, and it kind of breaks the inflammatory cycle of dry eye. So the key messages are post-cataract dry eye is an inflammatory process triggered by tear film instability and tear hyperosmolarity. Mild cases can be treated by lubricants alone. The dual polymer tear substitute provides increased tissue hydration and lubricity and protects the ocular surface from damage associated with dry eye. So in some ways, it's almost like a complete lubricant. And anti-inflammatory agents are indicated for moderate to severe, which have a component of inflammation as well. Try to identify with risk factors prior to cataract surgery, and then you can prevent many of these cases of post-operative dry eye. Thank you.
So the message you want to convey is that you should be using dual polymer rather than a single.
That that's means your personal choice, yes. But it
instead of using sodium hyaluronate alone, you say HP-GOR plus sodium hyaluronate is a better combination.
And PEG. So that's